All right, welcome back, everyone. We are now going to continue the panel sessions of our public meeting. I'd like to introduce our moderator for this particular panel is our very own patient advocate representative in particular, Mr. Armando Nahum.
Hello, thank you, Dr. Musmar. Hello, everyone, and good morning again. I am very excited and honored to kick off the first panel, which will focus on the power of patient advocacy to drive change. We will hear from 4 powerful voices in advocacy who will share their personal experience with resistant infections and how they have turned those experiences to make changes to public health and healthcare to help to fight against that resistance. Our panelists include Ms. Vanessa Carter from the World Health Organization AMR Task Force, Mr. Rob Purdy from MyCare, Ms. Luange Coffey, a registered nurse and Amahoro Coalition Fellow, and Dr. Rachel Freeman from IQVIA. I'd like to thank each of the panelists for sharing both their time and stories with the PACCARB. So, Ms. Carter, please go ahead.
Thank you very much for having me, and I apologize that I could not be there in person today. Could I just check that everybody can hear me?
Yes, thank you.
Thank you. Okay, so yeah, I'd like to start by saying that I am a patient survivor for antimicrobial resistance. I wear a few hats. I'm the founder and executive director of the AMR Narrative, which is a charity, a registered charity in the UK. I'm also a lay member of the UK government's antimicrobial prescribing and healthcare associated committee. I'm a patient member of the WHO Task Force Strategic Task Technical Advisory Group. I'm also the chair of the WHO Task Force of AMR Survivors. And thank you very much for that kind introduction, also outlining what I do. Could we go to the next slide, please? So this is what I call my last photo at age 25. You know, on the left-hand side, I was a very ambitious girl. On the right-hand side, this was our 3 generations, me, my mother, and my grandmother. Next slide, please. Shortly afterwards, I woke up in the high care unit in the Johannesburg Charlotte Maxey Care Hospital on ventilators because we had a horrific car accident. And I had multiple injuries. I had a head injury, facial fractures, major abdominal injury, fractured pelvis, neck injury, back injury. And, you know, being in a public hospital at the time, it didn't look very well, you know, it didn't look very good for me. You know, following on from this, I had a very extensive recovery, learning to walk again, getting used to the visual impairment that I had because I also lost the right eye, and getting used to the facial disfigurement that had happened during the car accident. Next slide, please. So even though I had all these injuries, 10 years following that, the most extensive were to my face. And the reason being was because I needed to have different types of prosthetics implanted. I needed to see different types of super specialists, you know, and, you know, it was just a horrific journey that I had to go through. Next slide, please. So in my 6th year, I had a prosthetic implanted that, you know, kind of tried to rebuild the cheekbone. And, you know, I went to the grocery store one day. I came out and I felt this moisture on my face. I got into my car. I pulled down the rear view mirror. And, you know, I thought the moisture was probably tears coming out of my eyes. But when I pulled down the mirror, I saw this pus coming out of my face. And I panicked. You know, I phoned my doctor's offices and I said to them, you know, what is going on? And he said to me, you know, this is potentially an infection on the prosthetic. we need to get you into the hospital, and we need to do a debridement, meaning that they needed to clean the prosthetic. So we did that, and I was discharged. But 2 weeks later, the infection came back again, but this time worse. So we did the same procedure. You know, I came out of hospital, but this time the infection came back and it was even worse. I couldn't get rid of this infection. So, you know, what started to happen was I was kind of passed between doctors. I was sent from my plastic surgeon to my ENT surgeon to my maxillofacial surgeon to my ophthalmologist and so on. And they were all prescribing antibiotics between them, you know, saying, you know, take this antibiotic, go see your plastic surgeon, you know, there's going to be a bit of a wait. We'll do some surgery, we'll do sinus drainage, we'll do this, you know, so that as I say, that kind of carried on for 11 months. So this picture that I put on the left-hand side is kind of what I went through, because, you know, it was kind of going from, you know, doctor to doctor to doctor, prescribing antibiotics, and nobody had the right advice for me. So if we could go to the next slide, please. So this is what I call, this photo is what I call my point of no return. You know, when, you know, half my face was kind of eaten away by this bacteria that was on my face. I didn't know what was going on. You know, they'd removed this cheek prosthetic, and I said to myself, I want to see the diagnostic test. I want to know what's going on. So on the right-hand side, you can see what they sent through to me. At the top of the test, it said MRSA, lots of R's and S's on the right-hand side, lots of different antibiotics on the left-hand side. And when I, you know, turned to the internet, it said to me MRSA was a type of antibiotic-resistant infection, and suddenly, you know, this kind of made sense to me, you know, what was going on. So if we can go to the next slide, please. So at this point in time, my doctors had given up hope on me. You know, they said to me, we don't know how to fix this because we know that you're a very high-risk patient. If we can't operate for another year, if we touch that area, you know, what do we do? And so, you know, I guess during that year, what I did was I got on the internet again, and I started to send my medical history to different doctors around the world. And I was very lucky that one doctor at the Brigham and Women's Hospital in Boston got back to me, and he said to me, I see cases like yours all the time. What you need to do is you need to cut the bone, so what they call a zygomatic osteotomy. No more foreign objects, you know, avoid foreign objects. Don't go with any doctor that tells you that. You know, and this is what you need to do. So I went back to Johannesburg. I just want to mention as well, we had a shortage of craniofacial surgeons. We had like 5 craniofacial surgeons in Johannesburg. In the USA, there were like 100 craniofacial surgeons. You know, so, you know, this kind of adds to the whole surgical planning and surgical access to surgical procedures in countries like ours, you know, South Africa and infection control. So, yeah, so I basically found a doctor in Johannesburg who could perform these procedures. So on the left-hand side is a 3D printed model of my skull, and he did a practice round just before the day of my surgery. And on the right-hand side is kind of what my face looks like now. It's put together with a lot of titanium, a lot of prosthetics and so on. And it worked out great. It really looked amazing. If you can go to the next slide, please. However, I did get an infection back again, this time in the bone and the skin. I had also developed an allergy from the antibacterial ointment, which I use on the surgical side. You know, normally they put Bactroban and so on your surgical side. So we had to stop the antibacterial ointment and also rotate end-of-line antibiotics for a couple of months, probably about 4 months. Next slide, please. Until eventually I started my presentation saying that was my first photo, my last photo, when I was 25 years old. This was when I was 35 years old, when I felt like I could finally uncover my face and walk out into society again. So you've all asked me to present not just on the patient story, but also talk a little bit about communication. So if we can go to the next slide, please. So for me, some of the biggest problems in my journey was antibiotic stewardship, including me as an antibiotic steward, explaining to me, how to take my antibiotics at the right time. Doctor, Professor Reinecker, that did my zygomatic osteotomy, explained this to me. He said to me, if you've got to take your antibiotic at 5 a.m., set your alarm, do not give this bacteria a 20 minutes window to mutate. And that never happened with other doctors. So I personally feel that we need to be thinking about communication between the patient and the doctor, patient and the pharmacist. Even a sentence like, if this infection doesn't go away, come back to me and tell me, so that we can make sure that resistance to this antibiotic hasn't developed. Patient empowerment. Let's talk to patients, especially also about infection prevention control. When I first had my infection, doctors would say to me, or nurses would say to me, keep it clean. And I didn't really understand what that meant. Those words, keep it clean, had no meaning for me, So, let's talk a little bit more about when we empower patients. What does that actually mean? Wash your hands every 30 minutes, sterilize everything around your home, don't bring computers into the hospital, for example, or if you're on your mobile phone in the hospital, make sure that you are actually sterilizing that, as a patient in that setting. Care coordination, one of the things that Dr. Reinecker said to me is, if any other doctor prescribes you an antibiotic, tell them you are now under my care. There was no doctor that said that to me, because we didn't have diagnostics that could show, in South Africa, what that actually meant. So he made a huge difference for me to say, well, now I'm going to my GP and I think I've got cold or flu, so I need an antibiotic. Well, actually, you're trying to sort out this infection, but you're under the care of Professor Reinecker right now. He's just prescribed an antibiotic. You need to know what that actually means. So next slide, please. So this is, before my whole patient journey, I was working in marketing. And I think that one of the things that kind of probed me into becoming an advocate was, the lack of communication. So this photo for me was like really frustrating, because I went around hospitals and I was like, so where's the communication? It's not just between doctors and patients, but, where's the posters? So this was actually funded by USAID. And what really frustrated me was, the poster is okay. There's not much about, actually what antibiotic resistance is, but it was put into a back room where patients couldn't even see it in the first place. And so this really frustrated me. Next slide, please. So this is the UK where I live now. I've only been here for the last 3.5 years. And I made a comparison, and, I went to my GP surgery and I was kind of like, okay, here you've got like loads of pamphlets and flyers. And as you can see, there's like bunting going across the roof of the GP surgery and so on. A lot of these flyers could be telling us about AMR. They've been funded and they've been printed by charities that focus on, for example, cancer and urinary tract infections and so on, but there's nothing about AMR. So I think that we need to be, thinking more clearly about how we can tap into these charities, tap into these, individual organizations to empower patients, even more so on an individual level where it means something to them. Next slide, please. So I love to use a slide because I was in ICU beds a lot during my journey, my 10-year journey. And I always said to myself, when a doctor says keep it clean, that's great. We've got all the hand washing posters, the 5 moments of hand hygiene. And so, above the sink, above the basin in the hospital care. But, you sitting in a bed, you sometimes can't move from your bed. And I think that patient education needs to be meeting patients at their own individual spaces, as it does in terms of an aeroplane. If you're flying for the first time, you're educated around flying safety, how to open the emergency door and so on. And this needs to be happening more in hospitals. And, I could talk about this forever, but I've only got 15 minutes. So, yeah, I just say, think about more how you could make patient-centered interventions in terms of teaching people about RPC, and taking antibiotics and antimicrobial stewardship as well. Next slide, please. So also patient-centered design makes a difference. When I was searching for information about AMR, this is what I came up with: lots and lots of studies, lots and lots of journals, but we need to be talking in patient language, and they would probably be in the sense of videos, lay descriptions and so on. So if we can go to the next slide, please. So for example, this is something that I've worked on with the UK Health Security Agency. You can see my name at the bottom, where we did a lay description describing surveillance and AMR in the UK, working with health professionals and so on. So, whatever you do as a political, as a governance, you need to be reaching patients and the wider public. And the only way to do that is to try and create lay explanations of exactly what you're trying to do. Next slide, please. So, this is an example of a patient-centered workshop that we did at Stanford University in 2017. I actually applied 5 times for this, and eventually I got accepted. And so this was, they put me onto the presenters track at Stanford University, and this was totally amazing because it was like a mix of patients, healthcare providers, digital technology professionals, researchers, and so on. It was a workshop moderated by IDEO. I don't know if you know who IDEO is, but they've worked extensively in Silicon Valley. They're very well known, and so this was basically to come up with co-create solutions for COPD. So I guess my point is, include the patient, include civil society, include all these people on the ground, communities and so on, so that you understand exactly what is needed to create solutions. Next slide, please. So this is an example of the UK. Obviously, Stanford is like, so much more advanced, but the UK is really so advanced too. This is what we call the NHS NIHR Involve project, and yeah, I've worked quite a lot with them as well. And again, it doesn't just extend to policy making, but also medical education, research, co-creation, you name it. Patients and caregivers and community members are so important to making this whole holistic approach to AMR possible. Next slide, please. So this is a really good example. This is one of the examples of a project that Imperial College London have included patients and community members and the public in designing a website. It sounds like a simple thing. In fact, we even contributed towards designing the logo of the Fleming Initiative. So this is actually a center that will bring together public engagement and policymakers and so on, to talk about this very, very complicated, diverse topic, which we know is AMR. So, Prince William is the patron of this particular initiative as well. So, next slide, please. So I just want to quickly go back, and this is just before I end. Before we get carried away with higher income countries, Prince William and this and this and that, South Africa As one example, when we talk about LMICs, we have to think about things like cultural differences, health literacy differences. If we can go to the next slide, please. So, for example, in South Africa, the word antibiotic doesn't even exist. And this was an amazing study. This is some colleagues of mine that did the study. And, so I think I heard a little bit early on, today that when we start to work in LMICs, we need to be thinking about these things. We can talk about AMR all day long. Antimicrobial resistance, for example, is a word that most people can't even pronounce. COVID is a good example because in South Africa, they wouldn't have called it COVID-19. They might have called it the corona, so we need to be taking this into account, and, not necessarily changing it all, but just considering that these different cultures and so on don't quite understand things. For example, like superbugs. A superbug in South Africa might be, using the word in Afrikaans, which is like an actual bug, So if we can go to the next slide.
Carter, could you please wrap up quickly? Thank you.
Yeah, we're going to the last slide now. So that's the next slide. And then I think the last slide is coming up now. No, you can go. You can keep going. Sorry. And next one. Next one. Yeah. Okay. So yeah. Okay. So I'm going to wrap up now and just say that, we as a WHO Task Force of AMR Survivors is what we formed right now. Stories are the most important things that we can do, to basically share the what it means to have a human face to AMR. Next slide. And these are some of the activities that we've done. And yeah, I don't want to take up everybody's time, so we can go to the next slide. And if you've seen the campaign on social media, this is it. Antimicrobial resistance, AMR is invisible. I am not. And I believe Rob is going to speak next, so I think he's going to say a little bit more about this as well. So thank you very much. Next slide, and I think that's it. Thank you.
Ms. Carter, thank you so much for your presentation. I really commend you for it. I can't begin to wrap my head around what you went through, so thank you again. If you could please hang on tight with us until the end of the fourth panelist, so I'm sure there'll be some questions for you. So thank you again. And next is Mr. Purdy, please.
So thank you for having me here today, and I'd like to apologize for this first slide. I realized after I submitted that I spelled PACCARB wrong. So please accept my apology for that misspelling, but thank you for having me here at PACCARB. Next slide, please. These are my disclosures, and unfortunately, all the opinions are entirely my own. Next slide, please. So my symptoms began on New Year's Day of 2012. So I basically describe my onset of diseases. I woke up New Year's Day with the worst hangover of my life. Some of you may be able to relate. The difference was I wasn't feeling good on New Year's Eve. I went home, went to bed early. So after a couple weeks of horrible headaches, went to an urgent care. They said, oh, it's a sinus infection here. Empiric antibiotics 1. Completed that course of antibiotics, no better. So obviously that doctor was an idiot. So I went to a different urgent care. Same diagnosis, different antibiotic. So finally went to an ENT on my own. He said, I don't know what you have, but you do not have a sinus infection. Was lucky that was probably saved weeks of my diagnosis process, just that lucky thing to say, I'm going to go to an ENT, pay out of pocket and do it. So next I was told I had cluster headaches. And then in mid-February or early February, I was presenting at a small meeting, and my wife was with me because she had been driving me and helping me and was my assistant and partner. And I said, well, how was my presentation? She said, oh, you know, it wasn't bad. It wasn't your best. I said, well, about halfway through it, I started seeing two of the screens and I wasn't really sure which one to read. So went to the local hospital, to the ED. They said, oh, you have a slight fever, you have vision issues, and you have a horrible headache. We have an idea what you have. A resident in the ED did my first lumbar puncture in the ED. I was admitted to the hospital. And so this picture is Valentine's Day of 2014 when I was given my diagnosis of coccymeningitis. So was released in March. Most of my symptoms started to go away in May. So I only had a headache for 5 months. And then I promptly was readmitted to the hospital in October because I failed my first drug. Next slide, please. So to give you a timeline of what that looks like, I was on 1,200 milligrams of fluconazole until about October of 2012. Then I was started on itraconazole, failed that one about 6 months later. Voriconazole 6 months later. So they added intrathecal amphotericin to my voriconazole via this little bump on my head, which is actually an Ommaya reservoir. And so voriconazole plus amphotericin was actually fairly successful. I was started it twice a week. Which basically means I show up at the doctor first thing in the morning and I leave about the same time as the nurses in the afternoon. It's an all-day thing and it's not pleasant. I failed voriconazole because I was diagnosed with squamous cell carcinoma because I was prescribed a much higher dose than the FDA approved originally. So that little note about sun sensitivity means a lot more to me in valley fever patients than it does to those that are receiving it otherwise. And then I failed amphotericin, built up in my system. I actually was unable to walk or urinate. And in case you're wondering what happens when you fail amphotericin, they continue to give you amphotericin, but they do spread it out because I'm reliant on that drug. Now I'm able to spread out my treatments to about every 16 weeks. Currently on posaconazole and amphotericin. Next slide, please. So as I highlighted with the voriconazole and alluded to with the fluconazole, you know, the FDA approved dosages of triazoles are not the dose that's prescribed for valley fever. And even at the high doses that our patients are prescribed, it doesn't cure it, it just helps it go away. So, you know, at approved dosages, you might get this. And if you get this, stop, we'll do something else. And at the doses that I'm prescribed, it's like, you're going to have all this and more. Next slide. And that contributes to the burden of disease that we experience as fungal patients. Now, my own personal experience is that of a valley fever patient, but I've had, through my work with MyCare and other organizations, a lot of conversations with other fungal patients. And I have found that there are a lot of similarities in our experiences. So while my personal perspective is that of a valley fever patient, I do know from many fungal patients, this is a very similar experience. So we all talk about the direct cost, you know, especially when it comes to AMR, hospitalization, procedures, treatment, and testing are known costs. But what's much harder to quantify and is becoming more, there's a lot more attempts to do so through the increased use of PROs and other types of devices like that or forms. Deteriorating relationships. I missed 3 months of work. I was a sole provider for my family. It took a decade for my finances to stabilize after that, after my illness, at the cost of my retirement, at the cost of a lot of things. My retirement plan now consists of lottery tickets. So the financial costs of these fungal infections, even ones that are considered acute, is extremely devastating. And then obviously the depression and isolation that you experience. You know, we know statistically that 1/3 of chronic illness patients experience depression. I think that's a very underreported number. I think most people, including myself, wouldn't like to talk about our history with depression. Next slide, please. So a little bit about my disease. Valley fever is interestingly both rare and epidemic. So there's an estimated 150,000 infections a year, 60% of which are asymptomatic, 40% of which are symptomatic, including myself. 10% of cases are diagnosed. So it's a very underdiagnosed disease. And 1% like me are disseminated. I'm what my doctor called the lucky 1%. Obviously, he and I share the same sense of sarcasm. But the interesting thing about valley fever is I was diagnosed with a 70-year-old test, and I'm treated with a 60-year-old drug. And because of that, it's very difficult to control my disease. It's very difficult to diagnose my disease. And on top of that, since 2000, the cases of valley fever in the US have increased 5-fold. So it is both rare and epidemic. Next slide, please. Fungal infections in and of themselves are misunderstood and often unknown. I am the first person here, I think, today to have mentioned fungal. Viral and bacterial were mentioned. We haven't talked about parasitic, but there's an estimated 1.5 million fungal species, and 300 are causing diseases in humans. And most of those also will cause diseases in animals. There's estimates that more than 300 million people suffer from fungal diseases, and that fungi collectively kill over 1.6 million people annually. It is definitely an unknown and misunderstood pathogen. Next slide, please. And fungal pathogens are a threat to human health, biosecurity, and ecosystem resilience. So what's going to happen when we have to choose between using these fungal microbes? Again, not a scientist. We have to start deciding if we're going to use these fungal drugs on our food or our people. Do we eat, or do we starve? And if we eat, are we just going to die of a disease? And what's even more alarming is watching some of the animals. The most devastating thing I've ever seen is a dog with valley fever. So this is a One Health priority. And the challenge is, we know there's a lack of funding, but the biggest thing is surveillance. We don't know what we're dealing with. We haven't even appropriately identified the threat. Next slide, please. And additionally, as valley fever is a rare disease, many fungal diseases, almost all fungal diseases are rare diseases. Even invasive candidiasis, by definition in the US, would be considered a rare disease. And because of that, the number of patients is low. So it's difficult to engage patients. Then if you try and do so, even on a national level, there's going to be language barriers. So it's a difficult thing to address. Next slide, please. One interesting thing, and this is a study that was done on AMR patients in the UK. And their perspectives were that clinicians lack knowledge, information, and support. And because of that, patients lack reliable and plain information, and we don't understand what we're being diagnosed with and how we're being treated and why. Next slide, please. But at the end of the day, what we want physicians to be able to tell us what's wrong with us, which requires appropriate diagnosis. So I would like to, at some point, be able to appoint to a valley fever test that's only a decade or two old. You know, that's not old enough to drink. Treatment goals. We want manageable disease, manageable cost, and manageable side effects. I don't want people getting skin cancer because they had to take a drug that's not curative and has severe side effects. And at the end of the day, we all just want our life back, right? That's what everybody wants. Next slide, please. So if you've ever heard Dr. John Rex speak, you've heard the story of fire extinguishers, right? So if therapeutics are the fire extinguishers of medicine, and as he alluded to at the French Embassy event last week, smoke detectors are diagnostics are the smoke detectors of medicine. What else does that mean? Next slide, please. It means that ID is the FD. So infectious disease is the fire departments of medicine. So there's a question that we have to ask, right? There's a value proposition. What are we willing to expect? We in the United States believe that infectious disease is the fire truck on the right. This nice, shiny, brand new Seagrave fire engine. But the reality that I experienced was the fire truck on the left. If the fire truck in the left showed up at your house in an emergency, we would not accept that. If the people in this country whose family members were suffering with infectious disease understood the nature of their disease, they wouldn't be holding up protest signs, they'd be holding up pitchforks and torches. But unfortunately, people don't understand the value proposition. They don't understand AMR. And I've heard oftentimes that it's complicated and it's a difficult thing to explain AMR. It's not a difficult thing to explain AMR. It's a simple thing to explain AMR. It's just not an easy thing to do, because you have to reach people where they are and you have to have a multi-layered strategy to do so. Next slide, please. And there's the huge awareness gap, because oftentimes one of the problems that we have with the AMR messaging, we've created ourselves by focusing on using the word antibacterials within AMR. You know, ID therapeutics focus on antibacterials. We focus stewardship on antibiotics. Diagnostics are also a huge part of that, as are antifungals and others. And all the publications and papers that have been generated on AMR, they don't translate to public and policymakers. And people don't understand the difference between viral, bacterial, fungal, and Coca-Cola. They just don't. Next slide, please. So I do want to shout out to Vanessa and my other task force members for what we're doing and what the WHO has done with the Task Force of AMR Survivors by helping us elevate our story. Next slide. And I want to talk a little bit about what we can learn from AIDS activists. So, you know, AIDS is the AIDS epidemic is a blueprint to what we can do and what we can accomplish as patients and patients working with partners. You know, when Sarah Schulman's quote says, we have facing a disease with no cure, abandoned, that's how we as fungal patients feel. And I think Dr. Fauci had a great quote when he set up that ACT UP put medical treatment in the hands of patients, and that's the way it ought to be. Next slide, please. And I want to leave this here for you, and I'm only going to read one part of this FDA action handbook that was generated by ACT UP. One agency, the FDA, is actively blocking the delivery of promised drugs to PWAs and people with HIV. Other agencies sin by omission. They aren't doing enough. Only the FDA sins by commission. It's doing the wrong things, and they're deadly wrong. And only the FDA has the power under existing laws and regulations to change direction and provide many of our demands immediately. That's a very, very heavy slide. And I think that is important because the FDA responded to this. The FDA took the lead and said, you know what? We are going to make some changes. We are going to use our existing authority, and we are going to work to bring these drugs to market. That's something that the FDA can do. Again, imagine if the FDA comes forward and says, we want to help with AMR. We understand that these are mostly rare conditions. We understand there's difficulties with patient populations. We want to go back to our playbook for HIV and AIDS and pull that out of mothballs and do that for AMR. That's something that can be done administratively. That's something the FDA has the authority to do, and it's something I hope that they will consider. Next slide, please. I thought we could enjoy something.
Let's hope to Christ this works. Wait a minute. Yes? Yes, take a look. The cash particles have completely replaced all the HIV in Kyle's blood. Boys, you just found the cure for AIDS.
Oh, right!
They found the cure for AIDS! The cure for AIDS! What is it? Large doses of concentrated cash. Get the media on the phone.
All right!
Next slide, please. I didn't want it to all be so heavy. But South Park is hilarious social commentary, and it's hilarious because it's accurate. So what do we need? We need appropriations. We need the CDC to have the money to do their surveillance, as well as develop diagnostics. NIAID needs to increase funding for preclinical and late-stage preclinical services. We can't fill in the valley of death, but we can make the walls a little less broad. FDA can do things to ensure that they continue to value patient perspectives by including language in R13 funding mechanisms to have patient perspectives at meetings. That can also be done by all of HHS's centers. Next slide, please. Wrong way. Legislatively, it's all about push and pull incentives, right? Push incentives to maximize the usefulness of existing PRV mechanisms. Specifically, we have the neglected tropical disease PRV program. That would encompass and should encompass most endemic fungal diseases. Pull incentives like Pasteur that will allow us to reward success. Along with that, there's a bill called Superbugs that will help the State Department and other international agents of the US to create relationships so that when we have these pull incentives globally, that they work together rather than create a dam to prevent forward progress. Next slide, please. Administratively, as I said, BARDA, CARB-X, ARPA-H, all three of these entities have mandates, but they don't clearly identify fungal. CARB-X does not include fungal. It should include fungal. And along with that expansion of their mandate needs to come an expansion of funding. Don't give them twice the job and the same amount of money. Give them both. Don't make them dilute their current efforts, but give them the empowerment to address fungal. BARDA needs to have their mission clarified to include fungal diagnostics, treatments, and vaccines. ARPA-H, make sure that it also includes fungal. AHRQ, the PACCARB program has been amazing, and I think they need to continue to do that. And the FDA, I already kind of touched on, there's so much work that the FDA can do and so much that the FDA can lead on if they just choose to do so. They have the ability and the mechanisms to do it. They just need to do so. And I hope that they will. Next slide, please. And then obviously the only way to change the value proposition is going to be public-private partnerships. Next slide, please. And then last, my favorite quote, the people who are crazy enough to think they can change the world are the ones who do. I am happy to tell you that I'm crazy, and if you would like to be a little crazy too, I think we can change the world. Next slide, please. So please, join me, work with me. Thank you very much.
Thank you very much, Mr. Purdy, and thank you for bringing South Park to the PACCARB. And now we'll hear from Ms. Coffey.
Good morning, everyone, and greetings from Ghana. My name is Luange Kofi. I am a Togolese refugee living in Ghana. I'm a registered nurse, and I'm also with the Amahoro Coalition. And I'm so much passionate about health promotion, health education in displaced communities and even host communities. I'm very, very, very excited and grateful for the opportunity to speak to the team today. Next slide, please. Yeah, so this is just a little, information about me. My name is Luange. I was born in a refugee camp. That means that I had to struggle through everything, healthcare access and everything. Your parents had to carry you miles away from the camp to, to the health facilities and everything. Life was tough when it comes to access to health. And then the purpose of today's presentation is just to provide insight into the challenges we face as refugees in conflict zones, displaced persons and all, and the education we need and the challenges that we face. Next slide, please. Yeah, so obviously everyone in the room knows what AMR is. I don't want to dwell on that too much. Yeah, so that's just basically resistance of microbes to, the effects of medications that was once able to treat Yes, and it also has this global impact on humans and then funding and everything. Why do we have to address this issue very well, especially in conflict zones? You know, we need extra money or funds to be able to treat this kind of issues. Even now that we are in this refugee settings, it's even difficult and hard to get equitable access to healthcare services. So when we leave and then we don't do anything about this case, it's going to deteriorate, and then I don't know how we are going to battle this case. Next slide, please. And background, I can just say that refugees face numerous health challenges, including limited access to healthcare facilities, clean water especially, and then proper sanitation. I was born in a refugee camp. I stayed there my entire life. I remember leaving the camp when I was 20 years old. So I've seen it all. So I can speak on behalf of every refugee across the world. Having access to clean water is a challenge. Even if you have water, we have limited access to clean water. Yes, you can have water, but is it clean enough? Is it free of bacteria? That's one question that we can answer later on. And then with the issues of, having access to health facilities is a challenge. From the camp where I grew up, it was really hard. We didn't have a clinic or even a health facility in the camp. So you need to walk about 1 hour to the next town to have access to healthcare services. And even with that, it wasn't holistic. It wasn't, a full package. Sometimes you get to the hospital and then the doctors have to just do this trial and error thing on you. So they don't really know what's going on with you, but they don't do any culture and sensitivity tests. They just go ahead and prescribe something for you. Maybe, yes, it's a bacterial infection, but what kind of antibiotics is really going to work for it? They don't know. They just try. So go and try this. If you are not well, come back in a week's time, come back in 2 weeks. That's what I've experienced. I personally have experienced it. I had this skin issues and I kept going to the hospital for almost 6 months, and they were just trying medications on me from time to time. And luckily for me, I had to move from the camp with some funds. I had to raise some funds from the jobs I did, and then I came to Accra. That was when I was able to find solution to my skin issues, because I had to do culture and sensitivity tests to know exactly what was wrong and which particular medication, antibiotic I was going to use. So that's just on the side. And, for my family, yes, before I went to the nursing school, I was a corporate. You fall sick, you go to the hospital, you are given medication, antibiotics especially, and then within 2 days, when I get better, I just stop taking the medication. I don't continue till the end. And that was the case of my family and those around me. I didn't know about it until I went to the nursing school and then realized that was something bad that we were doing. And then I had to go back and talk to a few people. And now I'm with my contact with the council and all, I'm thinking of, expanding this whole project, because it's an issue that is mostly overlooked, but it's a serious case. And then education in the refugee camps also plays a critical role in empowering refugees to make informed decisions about their health and well-being, which we don't really get. Yes, I'm a health advocate. I move to the camps from time to time and talk to them, but funding is also an issue. So I'm not always there. I have to plan my trips there with the limited funding I have. So if we can get people or funding to push this agenda, it would be very good, so that we educate the refugees on the do's and don'ts, where to seek help, not only educating the refugees, but even the doctors that are attending to them is really important. Next slide, please. Okay, so I've spoken about my personal story. That's when I had the skin issue and I had to struggle, spend my money, with this trial and error thing. And one very key problem that refugees face, not only in Ghana, but across the world, East Africa, Central Africa, and all, is limited availability of healthcare facilities. So, and then the long distances that we have to walk. This is a key factor in determining whether a refugee would move to the hospital for treatment or not. So sometimes they end to do self-treatment, go to the pharmacy, just get something for their pain without doing the necessary tests to ascertain the exact cause of the disease. And I've seen a lot of people abuse, and a lot of refugees and displaced persons abuse antibiotics because first of all, they don't have the funds to go to the hospital to have access to the right services, and secondly, the distances. One way of solving all this is to have the facility very close to them in the camp. If we have to build a healthcare center, not necessarily a hospital, but somewhere that they can have a first aid and then maybe a means of transportation to the bigger hospital, it would be very good. And then we don't have specialized care at the hospital, so it's just a general doctor you go to, and they just look at you, check your vitals, and they just they just prescribe something for you to take, which is really bad. And then the limited availability of antibiotics and diagnostic tools. I've touched on this, and I still want to talk about it because of its importance. Yes, we need machines, technologies that can detect the particular bacteria and the medication to treat that particular bacteria. And I believe it's going to really minimize the inappropriate use of antibiotics. Next slide, please. Clean water, yes. Most of the refugee camps have water, and others are also struggling. The fact is that those water bodies are not really clean. So refugees mostly resort to buying sachet water, and most of those sachet waters are really produced by quacks. They don't have certified factories, so they just bag the same water that we are running from. They just bag the same water and sell to us at a certain amount of cost. And then this worsens the spread of antimicrobial resistant infection in refugee populations. It's not just from the hospital or maybe from the doctors, but even with the water we take. And it circulates even with our animals, because most of the refugees are mostly farmers. They rear animals and they drink the same water. We end up eating the same animal. So I believe that it's a cycle. Next slide, please. We are spoken about this, that there are no available health facilities in the camp where I stay. And it's not just where I stay. Even with the 4 other refugee camps in Ghana, we have the same issues. And I believe it's the same in all other refugee camps across the world. And traveling to long distances to the health facilities is also an issue. Then limited access to tests. So I've just listed a few points of our challenges, our very specific challenges. Next slide. Yeah. I've also spoken about the overuse and then the misuse of the antibiotic drugs among refugees. We tend to do self-treatment a lot, which is really having an effect on our health. And then lack of proper antibiotic stewardship measures. So we need programs in the refugee camps that will promote the use of antibiotics and then reduce the development of AMR. So this is where the health promotion comes in. I am a nurse, I'm doing my part, but I can't do everything. We need funding, we need people on the ground, we need volunteers, come down, partner with people, educate, maybe organize maybe a 3-day workshop or something with the doctors so that they have the protocols, the appropriate ways to treat refugees when they come up with issues like this. The inappropriate antibiotic use contribute to the development of resistance, especially among the displaced communities, which further leads to treatment failure and then high mortality rates. Next slide, please. Now, the advocacy efforts and my recommendations today is to include refugees in the formulation of health policies and even things that affect them. Let's employ the use of human-centered design. So we have to create for the people, by the people, and with the people. So we don't just sit in a room and come up with a solution for the people. Let's mingle, immerse ourselves among them, learn about their problems, what they think the solution should be. I believe that's the way forward, and is really going to change the issues of access to health with regards to displaced persons and refugees. Let's also improve the healthcare access and antibiotic use in refugee camps. So it means we have to invest in the training of healthcare workers, implement stewardship programs in the camp and outside of the camp. As I'm talking, every recommendation or advocacy effort I'm talking about relates to both refugees and the host communities, because we mingle among them, and that's where we access most of our treatment and all. And then the importance of collaboration cannot be overemphasized. We really, really need to collaborate. This is where the One Health issue comes in. I believe a nurse like me needs to collaborate with a doctor needs to collaborate with a lab technician and all, so that we come together. So the key points that I want to leave with you today is, and then that's the challenges that we face. The first one on my list is the distance and transportation barriers to healthcare. Then healthcare facilities not available in the camp, yes, especially my camp and every other camp across the world. And then lack of proper diagnosis and treatment protocols. So we need to come up with protocols for these healthcare personnel so that they are able to discharge their services very well. We have limited access to clean water. I've spoken about this. Limited availability of antibiotics and diagnostic tools. And I just want to leave this with you that conflict exacerbates health challenges by disrupting healthcare services and infrastructure. So whatever we can do to reduce the cases of conflict across the globe, let's do that, even as healthcare personnel. Education cannot be left out of this at all. Let's bring out our voices, support refugees, young advocates who are speaking and advocating for the health of others. Let's just support them. Next slide, please. Yes. So collaboration. I call on governmental organizations, international organizations, individuals, labs, wherever we are, let's come together and work as a team. Now, call to action, I call on the PACCARB and every other person, stakeholder, to take action now to address the antimicrobial resistance in conflict zones and support refugees' access to healthcare and education. Next slide. Thank you so much for having me.
Thank you for that presentation, Ms. Coffey, and also thank you for taking the time to connect from such vast distance. We appreciate it. Thank you. And last but not least, we'll hear from Ms. Rachel Freeman from IQVIA. Please.
Thank you very much for your kind introduction and for inviting me to speak with the Council today. As already stated, I'm Rachel Freeman, and I'm here today to speak about my personal and professional experience with AMR, particularly antibiotic-resistant bacteria. For me, this journey starts back in 2005 when I first learned about MRSA during my second year at university. I attended a lecture as part of the medical microbiology module and heard how patients were going into hospitals and contracting methicillin-resistant Staphylococcus aureus, or MRSA, as we've already heard about today. And they were often dying as a result due to the difficulties associated with treating such resistant infections. I found this situation to be utterly unacceptable, and I am often asked where my drive to work in healthcare-associated infections and AMR comes from. And I will say that this is the point where something in me just clicked and I felt that I had to do something. I therefore opted to study as many microbiology modules as possible and went on to study for a master's degree in molecular medical microbiology immediately after completing my bachelor's degree. So I don't have time to go into great detail now, but my career in infectious diseases and AMR spans over 15 years. And during this time, I have worked in microbiology, infection control, epidemiology, public health, and consulting across a range of sectors covering healthcare, academia, government, and now the private sector, where I lead on AMR in our global public health team at IQVIA, which some of you may already be familiar with as a global provider of advanced analytics, technology solutions, and clinical research services. And through my diverse experience, I have viewed the challenge of infection and AMR from many angles. And in 2020, I gained a new perspective as a patient. So I cannot imagine that 2020 was a particularly good year for many people. For me, it didn't start well at all. In January, someone crashed into me on my way home from work, sending my car spinning, which resulted in me sustaining a range of minor injuries. In February, I contracted flu and went on to develop a secondary bacterial infection. So by March, it came as little surprise to me to learn that I had experienced a miscarriage. In my case, the embryo had not developed beyond 6 weeks, but my body continued to believe I was pregnant for at least another 6 weeks afterwards. This was extremely upsetting, of course, for me, my husband, and friends and family members that knew about the pregnancy. At this point, though, I had no idea just how wrong things could go. And on the 18th of March, 2020, I started to experience some bleeding, which I had been told to expect. But after a few hours, the bleeding intensified. I started to feel a bit faint. I remember thinking that I might need an ambulance, but I wasn't sure if I was overreacting. I also didn't want to panic my husband, who was at home with me that day, thankfully. But after I experienced more rapid blood loss, I had to ask my husband to call for an ambulance. And due to the report of heavy bleeding, they arrived very quickly. I can't remember how long exactly, but it was quick. I remember being led to the ambulance after being quickly assessed on my sofa and then being connected to a monitor in the ambulance. And I was feeling very faint by this point. And when I saw my blood pressure on the screen, I understood why. It was dropping fast. And when it reached 90/60, I asked one of the paramedics why we weren't already on the way to the hospital. In short, they weren't sure whether they needed to intervene medically at that stage in an attempt to stabilize me before heading to the hospital. So I told them I was still losing blood. And shortly after, one of the paramedics put in a recess call to warn the hospital team that they would be there with me in 15 minutes. On arrival, I was seen by several doctors. I had multiple cannulas inserted so that I'd be given fluids to raise my blood pressure and receive other medicines to try and stop the bleeding. Recognizing just how serious the situation was, knowing that I could die if they couldn't stop the bleeding quickly enough, I recall saying to one of the doctors, "If you need to remove my uterus to stop the bleeding, please do it. I mean it. I have a beautiful little boy. I don't need any more children. I just need to be there for him." Fortunately, the medical team managed to stop the bleeding and stabilize me. So I was admitted to the hospital for monitoring overnight and booked in for a scan the following morning to confirm if the miscarriage was complete. By the next morning, though, I was feeling worse. I remember asking which medicines I was on because one of them was causing like a strange plasticky taste as it was being administered. And I was told that I was being given amoxiclav because I developed a fever overnight and my heart rate was increasing. And later that morning, I had the scan that revealed that despite everything I'd been through, all the blood I'd lost, the miscarriage had not completed. And I felt absolutely devastated. I really didn't think I could take much more. And I really just wanted to go home, or at least I thought I did for a brief moment. Because shortly after having the scan, a medical registrar, I believe this is the equivalent to a resident doctor in the US, came to speak with me about the next steps. He said they were planning on discharging me. I immediately questioned this decision. He explained that because I was stable and the bleeding had stopped, I could go home where hopefully I would pass the pregnancy. I pointed out a couple of things to him at this point. Firstly, I had lost a lot of blood. Actually, I later found out that I'd lost approximately 35% of my blood volume. And I therefore felt that any further blood loss, particularly at home, would be very high risk. Secondly, that I had a fever and was only improving for an hour or so after being administered the antibiotics that I was on. And I was therefore concerned that I was developing sepsis. So Having provided this information, I asked him to speak to his consultant and reverse the decision to discharge me, which he did. And I remained in hospital, where it was decided that the consultant in charge would review me himself before making a decision to discharge me. As the day progressed, I could feel myself becoming more and more unwell. I was very aware of my increased breathing rate and heart rate. I felt absolutely exhausted, felt confused. There was one point where I went to the bathroom. When I looked in the mirror, I couldn't even recognize myself. And around 6 p.m. that evening, the consultant did come to see me. He asked me how I was feeling, and I said I felt better. He came over to feel my pulse. I think he may have also put his hand on my forehead. I remember he certainly commented on the fact that I looked clammy. He then walked to the end of the bed and said, "I think this miscarriage is making you very ill," to which I just replied, "Me too." And in that moment, the consultant made the call to expedite my surgery, told the team to get me ready straight away, and that no other patient was to go into the operating theatre before me. I woke from the surgery feeling confused but relieved. I remained in the hospital for another night, where I continued to receive IV coamoxiclav. But with increasing cases of COVID-19 in the hospital and me still being in a very weak and vulnerable state, the team were keen for me to go home as soon as was safely possible. So I was discharged later that day with some iron tablets, an oral course of coamoxiclav, and my discharge letter, where under diagnosis it stated septic miscarriage. And what I've shared with you today is one of the worst experiences of my life. What happened to me was terribly unfortunate, but on the other hand, I was also incredibly fortunate. I had access to the emergency medical care I needed. I had the knowledge to challenge medical decisions I did not agree with, and I had access to effective antibiotics. Now, due to my professional experience, I know how important data is, how important it is to monitor AMR, and the importance of data-driven decisions and action. So imagine my surprise, therefore, when I read in the national report published by the Public Health Agency in England at the time that over 40% of E. coli bloodstream infections reported in England in 2020 were resistant to coamoxiclav, the empirical antibiotic I'd received when treated for sepsis. The pace at which antimicrobial resistance and antibacterial resistance is escalating is alarming. And knowing how unwell I was on admission to hospital, I am acutely aware that had I not received prompt treatment with an effective antibiotic, I would not be here today. Now, clearly, I believe that we need a data-driven response to infection management and AMR. I expect that you, like me, want to live in a world where we can treat bacterial infections with effective antibiotics and where we can continue to realise the benefit of medical advances because we have effective antibiotics that allow us to safely administer new cancer therapies and perform surgeries, for example. But with bacteria evolving and developing resistance faster than we are discovering and developing antibiotics, the threat posed by bacterial pathogens is increasing and our treatment options are diminishing. But we need more than data to drive our response. We're all patients when it comes to being treated for bacterial infections. And in fact, I suspect that many of you here attending this meeting today could recount an experience where either you or a loved one has had an infection requiring antibiotics. And I think it's important that we all share our experiences and talk more openly about how infections have impacted our lives, no matter how difficult that may be, so that we can raise awareness of how effective antibiotics have allowed us to be treated for infections that could have otherwise killed us. And I believe that the conscious recognition of the crucial role antibiotics play in our lives now will enable us to realise that it's unacceptable that people are dying from bacterial infections now because they cannot access the medical care that they need, including antibiotics. That it's unacceptable that when we have the diagnostics data and technology available to us, people are not receiving the antibiotics they need to treat bacterial infections effectively. And equally, that it's unacceptable that when we have the diagnostics data and technology available to us, people are receiving antibiotics for infections that are not caused by bacteria, knowing as we do that inappropriate use of antibiotics will continue to drive an increase in resistant infections. Now, I'm passionate and driven to do what I do because I believe that we can rectify the unacceptable scenarios that I have described and provide health security for people now and in the future. But to achieve this, we need people to acknowledge the important role antibiotics play in our lives now. And with this recognition, we, and by we I mean society in general, can and should demand that action be taken now by all sectors and all disciplines to address the immediate threat bacterial infections pose globally and to prevent us from advancing to a situation where dying from bacterial infection is no longer just unacceptable, but unavoidable. Thank you for listening.
Ms. Freeman, thank you very much, and certainly for enlightening us on the importance of sharing your experience with infections. So thank you. And now we'll migrate to some question and answers. And please let me remind you that if you would like to ask a question, just flip your tent card. So we'll address that. Anyone?
And I just want to ensure that all of our virtual folks are still with us in case the question comes up. Thank you.
First, I'd just like to thank to all of you. I'm better make sure I get Miss Carter, Mr. Purdy, Ms. Freeman, Ms. Kofi. Your stories are what we need here. You taking the time to show your passion, whether it's on Zoom or in person, using some South Park to bring some light to something that's important. I'll say what I took across all four is something maybe we don't, I think, highlight enough, and that's in diagnostic delay. I think everybody kind of hinted at that from the beginning to the refugee camp, to even Ms. Freeman's last comments about this concern of diagnostic delay. And in Mr. Purdy's case, you said it nicely, right? Like, it took 5 months to get me a diagnosis, and then along the way, not only did I not have what I would hope was the best diagnosis, but I got a lot of antibiotics that everyone kept saying, "Hey, I had a sinusitis," and you're like, "Dudes, no, no." How do we elevate that? And I think you guys are helping us see that. But I say, as a council, how do we continue to elevate this notion of diagnostic delay in all of these settings, whether that is we need more diagnosis or not? And I guess I would put it, I mean, Mr. Purdy, you're sitting here in front of me right now, and your passion is, I can feel it across the room. I'd just love to hear a little bit more about your thoughts on diagnostic delay, and then open it up to the rest of these you wonderful members of the panel for this session.
So yeah, I'm very passionate about the increased funding for diagnosis. I think there's several issues that lead to diagnostic delay. The first and foremost is a lack of point-of-care diagnostics. In the U.S., the majority of us treat urgent cares as primary cares. In the absence of urgent cares being able to offer diagnosis or diagnostic tests, specifically for RSV, we do have COVID, but we don't have influenza, and we don't have a combination test that differentiates. And then in certain areas, you also have the issue of fungal. In the absence of that, it's empiric antibiotics, because you don't go to an urgent care to be told it's okay, go take Mucinex. And if you do, you never return to that urgent care, and that urgent care closes. And then the next one that opens learns from that mistake. In the outside of that, in other countries, especially LMIC countries where over-the-counter prescription, what we consider prescription drugs, are available, pharmacists can have the same issue where they have to provide a service. In the absence of being able to offer diagnostics, they're offering empiric antibiotics. So point-of-care diagnostics is a key. It doesn't replace, many of you here probably have advocated for additional reference lab capacity. That doesn't replace the need for that, but point-of-care diagnostics is the key. And that's a key to changing the balance, I think, of overuse of antibiotics in the U.S.
Would any of our panelists on the screen like to comment additionally?
I'm very Happy to. I think diagnostics are crucial to drive appropriate treatment, effective, appropriate treatment early. And I don't know many other medical specialties where you prescribe a treatment without performing a diagnostic. And I agree, point of care diagnostics, even if it's just to, in the first instance, suggest that it's a bacterial or viral or fungal infection in the first instance would be a good place to start. And then, yes, later on, as you start refining which antibiotic needs to be prescribed, absolutely agree. You still need the laboratory capacity to say exactly which antibiotics are required. But in the first instance, it should be what type of treatment should I be prescribing? Should I be giving you an antibiotic for your viral infection? Obviously not. But beyond diagnostics, there are other ways of kind of pointing to the initial right answer, I think, alongside diagnostics. And I mentioned it, data. So much data available that people can, in some countries, use to identify whether a patient should be, considered more cautiously than others in the absence of diagnostics. But ideally, we would have diagnostics to be guiding initial treatment and subsequent treatment.
Anyone else?
Yeah, I'm happy to go as well. I think from a patient, can you hear me?
Yes.
Yeah, I think from a patient perspective, one thing that changed my trajectory was to have the diagnostic in front of me, to educate me as a patient, to understand exactly what was happening. So I think the diagnostics also act as a communication tool, for a doctor to communicate with the patient exactly why they shouldn't be prescribing the antibiotic in the first place. So they can see it's a bacterial infection, for example. And, in my case, it was 11 months down the line. Why did it take so long? And being a patient advocate at the moment, I've walked through microbiology labs, and I've seen that in England, for example, there are ways to, to do diagnostics a lot faster, but when it comes to funding, that's not happening. It's not happening as quickly as it should. In South Africa, I don't even want to talk about that, but that's just in England. So, we need to be including this into our policy making. Very, very prominent, very, very prominent. Because what we're doing right now is prescribing antibiotics very blindly. And I don't think it's acceptable when people are losing their lives.
Thank you very much. We're quickly running out of time, so we have time for 4 more questions. Craig, I think you go next. If you could just limit to 1 quick question each.
Thanks. And I actually just want to have a comment. I just want to really commend the panel for being exceptional in sharing your story. I think it is underappreciated, and every advocate who shares their story, we all deserve to give you just a tremendous thanks, because ultimately, sharing the stories, raising awareness is a fundamental aspect of what we need to do to get ahead of this problem, and your contribution to that is important for not only us to hear it and heed it and to try to seek policy change, but for you to make those human connections that make so much of an impact on others and helping the general public and policymakers and others raise awareness to it. And I think the other thing I would just highlight from this panel that also appreciated is that this panel really highlighted awareness, and they also highlighted resources. And I think that's another thing that I think is really underappreciated. I really liked what we did in the global document, because it highlighted the need for resources and really underpinned that we know what to do for a lot of the problems that we face on antimicrobial resistance. We know a lot of the solutions. The issue is we need to resource them and raise awareness of them. So really want to just underline and thank the panel for highlighting those 2 key points. Thank you.
Thanks, Craig. Next, Lynn.
Thank you. I want to echo how important and powerful these messages are, and to thank you for sharing them with us as well as the audience broader. A couple of reflections. One is we heard it from Maddie in the film. We heard it from Ms. Carter and Mr. Purdy about the need for multiple options. Just having one antibiotic, one antifungal, one whatever is not going to be adequate in the future. And so we need to be more robust in terms of the spread of the portfolio in multiple solutions. And then Nurse Kofi talked about, we're talking about in best of circumstances needing these solutions, and then now an environment where access to care, access to clean water, et cetera, some of the other fundamentals were highlighted, which I thought was incredibly important. And then Dr. Freeman, I think you brought up another important interplay, and that's between AMR and sepsis community. I think there's a lot of overlap and a lot of co-promotion that can be done in terms of advocacy initiatives, et cetera, between those two disease scenarios. So thank you very much for sharing that with us.
Thank you very much, Lynn. Dennis, you want to go next?
So a couple of reflections. We certainly share the passion of our panelists and echo the importance of diagnostics. And just so you know, it hasn't fallen on deaf ears. We've been making major efforts for over a decade on diagnostics. We have not seen the returns we would like. So to Mr. Purdy, the Valley Fever clinical trial that we switched to a clinical study, that's one way to increase awareness of the disease. Just do a study on it, because we saw the prior antibiotic doses for a typical cocci case fall from like 3 or more, like Kaiser Permanente symptom, down to 1 or less, because they learned to look immediately for valley fever. That doesn't show up in a publication, but it shows what the effort yielded and how hard this is. I think the second would be the need for corporate cooperation, in that we have a dependency on companies just like we do for antibiotics. And for Aspergillus, we invested millions of dollars to collect an FDA-ready positive bank of samples that could be like your IDE to go. And we could not get a big company to step up and ask for them to develop a diagnostic, because I think they didn't see the return on investment. I'm not sure about that. And the third is, that's a quick way of saying it's a big issue there, and it's a complex formula on return on investments. And the third would be rapid diagnostics for bacterial infections. I wish we had time to ask Dr. Patel to talk about all the things we're trying to do there in the ARLG, and what the challenges are and what some of the successes are. But it's just that attacking the problem, it's like the boxer that trains for so long and never makes it to the professional title fight, because there's so much to get through before you get there. I don't know if that gives Dr. Patel time.
Thanks for your comment, Dennis. Robin, do you want to go next?
Yeah, I mean, I can't resist talking about diagnostics. I think that contributing to the way we use antibiotics in the world today has been the historical lack of availability of good diagnostics. And so medical practice evolved to a culture of empiricism with regards to the use of antibiotics. Today, though, we do have a lot better technologies that can bring us better diagnostics. Just look at what happened with the COVID-19 pandemic and all of the innovations that came out of that on the diagnostic side, on the point of care diagnostic side as well. So if a lot of that could be leveraged, and I think it can, we're in a place where that's possible to bring the right diagnostics to people, right? Not to hospitals necessarily, but to the people who need them to get their diagnosis quickly, to tell them, is this an infection or not? Yes, no. What kind of infection is it? And then most importantly, what treatment do you need to get better quickly, so that you don't waste that time getting treatments you don't need, being frustrated with the system, and risking your life, really, is some of the stories that we've heard today.
Thanks, Robin. I hear a lot about diagnostic, and I'm so thankful for the World Health Organization to bring forth for this coming September, this World Patient Safety Day, is diagnostic in safety and quality. So I really appreciate it. And I really think that in the future, AI is going to play a much bigger part on diagnostic excellence. So one final thanks to our wonderful panelists. Thank you so much for taking the time. Share your story. You enlighten us today. We really appreciate it. Thank you very, very much.
Thank you, Mr. Nahum. And I'll just kind of wrap up. You know, the team thought it was incredibly important for us to have an advocacy panel, especially after we voted on our global AMR report, to highlight some of the things, because each of your stories showed the intersection of several topics. The rate of mutation is alarming. Nobody realizes it, and that's what Rachel's story showed us, is that within 2 years, it's already changed and 40% resistance has already kicked in. The strength of advocacy in itself, to advocate for yourself when you're in a setting for healthcare, but also the strength of grassroots advocacy is incredibly important. So we applaud all of you for being part of that effort and ensuring that awareness and education are widespread as much as possible. The burden of disease, it's a loaded statement. The burden of disease has many, many, many facets to it and factors, and the burden of disease is not easily quantifiable, but we keep focusing on mortality, and we have to look at what the burden of disease looks like on the patient individually, but also on their family, the quality of life, what ends up happening, the repercussions after the fact that you have a single mode of treatment, but the side effects that it ultimately, you know, has and plays a toll on your body eventually, and you have no other choice but to use that and suffer. And also the intersection of climate change and AMR. Valley fever, there's an increase in temperatures. You're going to have an increase right now of fungal infections that are going around. I think it's an opportunity for the community to also work with the climate change community in particular. There are a lot of meetings that are happening. We're finally aware that the world is changing and our temperatures are increasing, which also means that we're pushing the fast forward on the button on AMR altogether, ultimately, from natural resources altogether. And then lastly, how the rest of the world lives. There are over 130 million refugees and counting. And disease, as we know, knows no borders. So I just want to emphasize the fact that on the heels of our global AMR report, the rest of the world doesn't live the same way that we do. And because of human interventions, we are pushing the fast forward button on the rate of resistance, which is our greatest challenge of our time right now. So I'll just close with those thoughts. There's more to come. We're switching gears for the afternoon. So we are going to break for lunch right now. We thank all of you for joining us. And folks, for those of you in the room, please be sure to be back here at 12:25. Thank you. And have a good one. No, 1:25, my bad. It's already 12:25. Just stay. Thank you. And for folks in virtual land, we'll see you at 1:25 Eastern time. Thank you all.
Produced by the U.S. Department of Health and Human Services.